Hello, this is an update of a previous presentation that was looking at including people with disabilities in WASH programs. We presented the initial findings a couple of years ago, and this second one is going into some of the more detail that wasn't covered in that previous presentation. So a quick recap of some of the initial findings. One of the things that people were doing in the initial stages of an emergency is they were only really providing communal facilities, with households following on much later on when you get to that level of detail. Now, one of the consequences of working at a community level, a communal public level, is you actually need to use a universal design approach. One size fits all, very rapid, increasing coverage quite quickly, as opposed to the inclusive design approach, which is used a lot in development contexts. But what you can do, of course, is combine the two. So start off with the universal approach in an emergency, and then actually switch to a more inclusive design approach to cater for the people who are still being left behind. And the practitioners did actually show that they often prioritise the things that an individual needs to do, like defecation and personal hygiene, and put those as more important than household level actions like laundry and collecting drinking water. And in turn, they were above issues of communal interest, drainage, solid waste, vector control. So you can see that when we're focusing on people with disabilities, we can set some priorities. One of the things we were asked to do was to compare approaches to people with disabilities to other vulnerable groups, and we identified four types of approach: a very proactive one for people who are large groups, quite obvious groups; reactive one, including people with disabilities; areas where there's no action, so people with incontinence, perhaps the elderly, babies, and carers, which was surprising; and then the unserved, people in remote and hard to reach places. So those headline findings were presented at the last EEHF, but there were a lot more detailed ones when we sort of began to get more into the information, and some further challenges. So issues such as, how do we actually find the people who require additional assistance? So they might be at home with poor mobility, there might be an invisible condition, perhaps mental health or incontinence, so much harder to find these people. And that is also coupled with the whole lack of monitoring and data, because you haven't got a homogeneous group of people. So it's not like addressing perhaps menstrual hygiene management or gender-based violence, where you've got a much more obvious cohort of people to support. And we've also haven't got a nice distinct boundary between what is WASH and what isn't. So it's no good putting making toilets accessible if people can't actually get to them in the first place. So should we start be thinking about things like walking aids, wheelchairs, crutches, or other things like that aren't WASH, but actually without them the people cannot access the WASH service. We also have the perennial problem of lack of skills and knowledge. Nothing new there, but we can actually see that actually the level of awareness was quite high. It was the systematic approach that wasn't so good, and also the detailed practice. And on that, the practical solutions, it's not just about ramps and handrails, and actually even if you're providing handrails, they've got to be in the right place and the right height. It might be about things like adapting hygiene promotion for people with visual constraints, and also issues to do with non-food items. It's not just about the facilities, but perhaps extra soap. And of course, all of this has to be in an emergency context, so there's definitely an urgency about it. So there's lots of time constraints, and often you haven't got dedicated staff, dedicated time, a real focus on this. You're trying to juggle it with lots of other things. So that's the reality of trying to provide services for these people. And there were two sets of recommendations. There were some that are quite simple, actually just summarising existing policies. There are lots. What is not easy to find out is what is the limit of a WASH response and what should be done by others, and how do you communicate between these various groups. Non-food items, mainly we need to just increase amounts of soap and laundry facilities for those who actually need that extra level of personal hygiene and laundry, but also the whole area of using containers within the home, potties, commodes, hasn't really been explored very much, especially when we're looking at the emptying. So not looking at a container-based solution with lots of composting, but just a much simpler, much cheaper action. Training, that was looked at. As we said, awareness was high. It didn't really need a tool. People actually didn't need to make the decisions or anything like that. They actually just needed more of the plain facts. If you were to do any more training, we'd need a much more specific training needs analysis. But one very simple thing is actually to have a bibliography, especially bringing in some of the humanitarian issues, and so we don't just use inappropriate development techniques. Now, those recommendations could be done quite quickly. There were some others that needed a little bit more thought. So one of the things that was found, if you can't measure it, you can't manage it, but you did need a WASH specific indicator. And we have approached the Washington group and actually said, could you have any questions on incontinence? Got a very positive reply, but we would need to provide them with research so we can actually work out how we can measure that particular issue. But very much about using perhaps the Bradley and White approach of water-washed diseases, waterborne diseases, but actually how we adapt our services to whole families of conditions that people might be dealing with. So on incontinence, actually there's a lot of, most people have incontinence, whether it's babies, pregnant women, people with medical conditions, elderly men, and actually we don't need to know the reason for the incontinence. A lot of the processes for dealing that will be very similar. And monitoring might be quite good for providing an evaluation, but you also need to check things are going well as you are working on a project. So this is where the idea of proactive feedback, quality assurance, so not measuring how many you've done, but checking what is being provided is actually meeting people's needs. So this is why issues like SANI tweaks could be very easily adapted to look at some of these issues. And then the final longer term one is the fact that we've been talking a lot about bringing in development processes more into humanitarian. Actually, this is one example where we need to have a distinct emergency fast track method for this context, and not try and use a longer term slower development context model. So bringing in a lot more on the universal approach, and seeing how we can actually speed up things like moving to household facilities, but it has to be starting from the emergency rather than from a much more perhaps rights-based approach that you may use in development. So that was an update on some of the more detailed findings of the project that was presented a couple of years ago. NCA did go on and commission another look just at incontinence this time, and again we get the same challenges: what is a WASH issue and what is a non-WASH issue. So trying to divide up the boundaries so we don't actually start trying to do too much or too little is one of those things that perhaps we should be thinking about more in the future. So any questions? I'd like to hear what you have to think about this.